not surprisingly, because of the clinical importance of flow cytometric measurable residual disease and acute myeloid leukemia, it's categorized as a high-risk test by IVDR criteria. And if you're talking in general purposes of its intended purpose, it is to monitor response to treatment as an aid to treatment choices, and that implies intensification and allogeneic transplant-related decisions, but also for time points after induction, pre-transplant and post-transplant. And more recently, for a growing number of us who are involved in the clinical trials, testing new treatments, not only is it incorporated as a exploratory or secondary endpoint, but also an enrollment criteria. So, of course, for IVDR and its sort of other laboratory development, you need to have your clinical evidence in the 3 strands of analytical performance, scientific validity, and clinical performance. And as a base for this is the published evidence source for the use of MRD. Now, this schematic diagram shows a summary of the published evidence source based on clinical trials. Not surprisingly, flow cytometric MRD is in bold because it's the topic of this talk, and because there's been a bit of bias, according to what our experiences. I put the UK trials on top, but no less important are the ones at the bottom. Now, this strand of published evidence is divided into 3 categories. The blue, the trials which showed that MRD was prognostically relevant for acute myeloid leukemia. And then the later trials are those which are showing the importance of treatment strategy, that changing treatment impacts the outcomes of patients if it's done according to MRD status. And then underlying all of this is the continued development of MRD assays. And part of this development has, of course, been within molecular MRD assays, including next generation sequencing, but also for flow cytometric has been the evolving leukemic stem cell monitoring assays. So taking all this evidence together, there has been a meta-analysis which included 11,000 patients based on results up to 2018, of which the greater majority was from flow cytometric MRD. But the ELN 2022 clinical recommendations for AML treatment have re-emphasized the key role for MRD in AML treatment. So for patients with non-adverse risk AML, and that's categorized by their baseline genetic factors, the MRD will drive treatment. So patients who have persistent MRD after induction or after consolidation should be considered for allograft if they are fit enough. But also MRD impacts the treatment of adverse risk patients, not because it changes decisions about whether they should go to transplant or not, but it will impact, from the evidence from randomized trials, what type of allograft they will be considered for example, myeloablative if they're fit enough, rather than non-intensive if they're MRD positive before transplant, and also whether they should be considered for preemptive therapy either before or post allograft. Now, for us to generate the assays that provide reliable results to the clinicians, we need evidence of analytical and clinical performance, and harmonization or standardization is an aid to that. And as we well know in flow cytometry, many paths lead to Rome. And for each of these paths, for example, cytometry settings, there will be multiple ways of getting there. I think the advantage of the accumulated evidence, accumulated experience for flow cytometric labs is that we can put all that evidence together and work out what the best practice is. But obviously, the disadvantage of it is that it can sometimes be a barrier to standardized comparable results between labs. So in this next part of the talk, I'm going to focus on the bottom part of that slide. So I'm not going to talk about specifically cytometry and settings, although there's obviously a lot of progress being made on that, or wet protocols. But I'm going to discuss, first of all, antibody panels, analysis strategy, and also sample quality assessment. So as you know, the ELN David group, which brings together a panel, a committee of experts who've participated in measurable residual disease assays in clinical trials and outside clinical trials, have a focus on helping guide how best to use MRD. And our consensus recommendations were recently updated in 2021. And there was also an article published in Hemisphere, which gave a few more technical aspects of flow cytometric measurable residual disease quantification. And one of the recommendations that we made in the 2018, but also the 2021, is that taken together, the 8 markers that provide the most robust and frequent detection of MRD by flow cytometry are these ones: CD34, CD117, CD33, CD13, HLDR, CD45, and CD7 and CD56. But also highly relevant when assessing a sample for flow cytometric MRD, of course, are the myeloid maturation and monocytic markers to understand what the maturation landscape is of the bone marrow. And then the CD38 with CD34 and LSC markers have been shown to be important for identifying what we now call LSC, immunophenotypic LSC. But since we recommended that 8-color core combination, there's been progress in technology. There's more colors with new cytometers. And some of you may have seen the MD Anderson group have recently shown how they validated their 12-color flow cytometry assay for AML. But there's also been more, new markers that people have proposed as being very useful for adding in to MRD panels. And I think one of the things that I've noted from the very interesting research data that's emerged from evolution of markers in AML MRD is that actually the new markers don't seem to have added very much. So there've been 2 approaches to identify new markers. The first approach is by gene expression array, as shown by this paper by Campana's group, where they identified 28 new markers. But in fact, if you look at their data, when they tested this on MRD samples, the markers that were finally incorporated and added into their MRD panel only identified less than 1% further MRD positive samples. And then another approach by the Dutch group enriched by proteomics markers that were overexpressed in acute myeloid leukemia at diagnosis, and then reduced it down to those that could also be detected an overexpression by flow cytometry. And there were some very interesting new markers, but there was also a lot of overlap between those markers. So any approach to knowing what's going to be useful has to be tested in a rigorous way. And one way to approach this is to gather the experience of multiple labs who are using residual disease monitoring very regularly and have it clinically validated, and to see which markers they find the most useful. So this is the strategy that we've used with the ELN. And we first of all did a survey of the 11 ELN laboratories to gather information on the panel composition. And interestingly, excluding the already recommended 8-color ELN core combination, there are 29 markers in use. So, and these can be divided in the categories shown below: asynchronous, lymphoid, LSE-specific, monocytic, and miscellaneous. And currently, we're progressing that and updating consensus markers for a 10-color tube, a 12-color tube, and up to 16-color tube, but also looking at what would be most useful for LSC monitoring, and in those cases where monocytic MRD would be of further value. Now, not surprisingly, with this webinar, my main focus is going to be on proficiency testing, because proficiency testing provides evidence of assay performance, so laboratory developed tests. And it gives us the evidence of any MRD, are the results comparable and accurate. And obviously, one way of doing this is by sample exchange schemes, but then the number of samples, a number of labs are limited to share fresh samples. And it's also, because the number of labs are limited, it's difficult to extract robust performance statistics. And then the second way of approaching it is by external quality assurance schemes, which you'll be participating in. And of course, UK NEQAS lead on this with their professional and experience. So most of the time we used to, in all our immunophenotyping, is we get samples and then we get reports, which are very helpful. So the AML MRD by UK NEQAS, in the current NEQAS program, 98 laboratories participated for AML MRD. And this proficiency testing uses stabilized EQA material with 4 distributions per year. And the lab's test is a test for panel processing analysis, because you're getting a wet sample. And now the MRD samples, as you know, also contain normal progenitors, although these are in fact peripheral blood stem cells. And as you all know, that from the reports provided by UK NEQAS, there's a robust mean, a Z-score with histograms of distribution, and a performance status for sample and the most recent 12 samples, which are plotted as charts. And then the Z-score gives us action or critical, and a negative Z-score will show whether you're underestimating your MRD value. So the latest EQA in August shows that actually, as a group, we're not doing badly, but that harmonization of results for interlab comparability continues to be a challenge. So looking at the robust mean and the robust standard deviation, you'll see that the robust standard deviation would give values of between 0.07% and 0.12%. But the ELN MRD threshold for positivity is at 0.1%. So based on that, some patients would be identified for suitable and should be directed to allogeneic stem cell transplant, and some wouldn't. So we do have some way to go. And to progress, we need to understand the obstacles that contribute to false MRD results. And EQAs are a very important tool to inform issues and guide changes in practice. And an example, a very good example of this is given by the ELN and NEQAS interlaboratory study for molecular MRD, which was led by Stuart Scott from UK NEQAS. And they showed that when they tested the PCR MRD with core binding factor and NPM1 mutant transcripts, that there was actually, for NPM1 mutant transcript PCR, a high proportion of false positive results in the EQA negative sample. And that a proportion of those could be attributed to the use of a specific highly active reverse transcriptase, which was more likely to introduce errors. And so therefore, that was something that could be actioned by the labs using that transcriptase and to guide practice. Now, when we're looking at flow cytometric MRD, I think we're all generally pretty good with this processing. The panels, as I said, we need this. We'll be moving those along in line with the progress in flow cytometers. But one of the main issues that people come across appears to be analysis and interpretation. So to try and understand the obstacles for standardized flow cytometric MRD results, the ELN and NEQAS collaborated together with a pilot wet exercise between 5 expert laboratories. And in this exercise, as well as the usual diagnostic and MRD sample, there was addition of a control sample as a reference to assess leukemic aberrant immunophenotype background different from normal analysis. And the lessons learned from this was that there were exercise confounders for harmonized values. And that was specific parameter autofluorescence due to the prefixation for stabilization. And there was also an reduced expression range according to the fluorochromes and markers used. And that reduced the ability to identify under or over expression. And then the control sample, the peripheral blood stem cells, were a very useful reference, but not entirely representative of the normal control bone marrows. So just to display this, the samples sent to NEQAS were stained fresh and then after fixation, and the fresh is shown on the top row. And in this diagnostic sample, the gates are those which would normally be placed to capture aberrant immunophenotypes. And in this sample, there was underexpression of HLA-DR shown on the second plot from the left, and also a subpopulation of CD7. And in fact, using the same gates as would be used by, for a fresh sample, there was loss of that underexpression of HLA-DR after fixation, and there was also loss of the CD7 subpopulation. So what would be lost or gained would be dependent on what markers people were using on their fresh sample. And there's also a recurring issue, particularly with the brilliant violet dyes, and that there may be autofluorescence which moves the whole range of expression up, as was the case in this sample for CD7 expression on brilliant violet. So because of that, between NEQAS and the ELN, we decided to focus on the development of an electronic EQA, because that would more readily help harmonize the analytical process of MRD. And to perform an electronic EQA, we started with FCS files of bone marrows, which was stained with the ELN AML MRD core combination shown above. And the pros that were for this exercise were that it would monitor the analysis of common and useful aberrant immunophenotypes in AML MRD, and that also we potential training and competency tool when a library of EQA FCS files were available. And also it would be distinct from any issues with panels and processing and sort of from analysis from how it's been processed. However, the cons of the scheme is that it wouldn't replicate exactly what was being done in the lab, because it would require an EQA specific analysis template versus the laboratory developed test routine template. And one of the aims for items for harmonization for the analytical performance in this electronic EQA would be the denominator used to calculate the MRD population size, the ELN marking staining intensity of diagnostic blasts, the presence and ranking of diagnostic labes. What is the aberrant immunophenotype quantified in the MRD sample, whether that's diagnostic or emerging different from normal, the MRD value, percentage and events, and also, and importantly, the background from the normal control, and then finally, the LOQ by events criteria to assess sample quality. And I'll be talking about this a bit later. So what did we learn from the first two pilots? Well, the important confounders for harmonized values were whether the labs were using, the expert labs were using CD34 positive or CD117 positive derived MRD for reporting their MRD percentage. And that was particularly important if there was a dominant aberrant immunophenotype change for expression of CD34-117 between the diagnosis and MRD. And then the other confounders are whether people were selecting out, whether they would select the diagnostic aberrant phenotyping or an emerging different from normal for the MRD value. So just to show you, some of the readouts from the these EQAs, the sort of first is by consensus, and the ELN marker staining intensity of diagnostic blasts and the identification and ranking of common diagnostic leukemic aberrant phenotypes. And you can see the tables below. So you get a result and you get the consensus. And this was, as all the reports I'll be showing later on that were produced by Matthew in NEQAS. See, we've not only asked for diagnostic blast staining, but we've also asked specifically for what people identify as the diagnostic aberrant phenotype, not only on diagnostic blast, but actually separating those into CD117 positive and CD34 positive. And then people will also be ranking what their first diagnostic aberrant phenotype they would be using for MRD. And then, in the form that's being asked to fill is what is the aberrant immunophenotype quantified for MRD? So for people to make an active choice, is it diagnosis or is it a diagnostic different from normal? And if it was a different from normal, that means an emerging aberrant immunophenotype, what was it? And if there is a difference between CD34 positive blasts and CD117 positive blasts, please specify the differences. So, finally, we have a participant-specific report for this exercise with a Z-score by consensus. But there's also, within this participant-specific report, what we call performance by reference value. So what do we mean by reference value? Well, what has been done for the latest pilot EQA is to spike in a known number of diagnostic blasts within an aberrant immunophenotype gate into the control bone marrow, so that the MRD sample has a known number of aberrant immunophenotype cells. And that known number is the reference or the maximum MRD values. So, for example, in the plots shown below, you have the diagnostic, and there's a clear 7 positive, 33 positive aberrant immunophenotype on 117 positive blasts. Now, a certain number of events from that gate were spiked into the control bone marrow, which is the plot on the right, and that produced an N number of reference events that could be assessed against. So the tables that's produced for this analytical performance gives these range of fields collected, which mirror onto what we were trying to harmonize, including the total CD45 positive events, the calculated percentage LOQ, the total 34 positive events and 117 positive events, as well as the MRD events and MRD percentage. And then finally, whether it's categorized as MRD present or absent based on the 0.1% cutoff. Now, as you'll notice in that table, as I mentioned before, one of the things that is going to be really important for us as a group to standardize is the use of the absolute limit of quantification. And many of you will be familiar with this as a concept from myeloma, CLL, and even acute lymphoblastic leukemia, MRD, when limit of detection is based on Poisson's statistics for what's a reliable number of cells to give an acceptable CV, and the limit of detection 20 to 30 and limit of quantification of 50 to 50 cells. Now, this absolute limit of quantification is a way to allow harmonization of sample quality assessment for AML MRD and would be critical to qualify a negative result. So you'd be calculating the absolute limit of quantitation based on the leukocytes, the CD45 positive events that you've acquired. And the sample LOQ of 0.01% is possible if 500,000 leukocytes required, which, as you know, is what we recommend, 500,000 to 1 million by the ELN recommendations. However, you can acquire 500,000 leukocytes, but that 500,000 leukocytes may be blood with no blasts. So the next steps to consider for development, a blast LOQ, we would need 500 blast events to detect MRD present, target present in 1 to 10 blasts. And we should also be assessing hemodilution, whether that's done in a semi-quantitative or qualitative way, particularly if the MRD value is less than 0.1% and therefore may be underrepresented if hemodilute. So, continuing on the use of absolute limit of quantification, AML, MRD, I think one thing that's very important to stress in AML, MRD is that the target background, the flow MRD target, may actually be higher than the absolute limit of quantitation, and this differentiates it from myeloma or CLL, where a gate is usually truly empty. And this is one of the reasons for as well as the prognostic validation in clinical trials, but also the sort of laboratory experience. One of the reasons for the 0.1% threshold is because the significance of less than 0.1% events in a aberrant immunophenotype gate will depend not only on the sample quality, but will depend on the target background. Now, in the example that I showed you for the EQ8 exercise, for example, in the control bone marrow, which gave the background for that particular aberrant immunophenotype gate, there were actually 60 cells, which was more than the absolute limit of quantification. But that 60 cells still gave a MRD value of less than 0.01%. So that brings me on to analysis strategies and the considerations for performance and harmonization. And you'll be familiar with the terms of leukemic aberrant immunophenotype, which is a leukemic immunophenotypic footprint. And the number of Boolean gates and exact gate positions does vary between standard operating procedures, operators, and samples. But it is possible with LAPE to achieve an MRD negative, which is less than the absolute limit of quantification, if you have multiple Boolean gates and an empty space footprint. So the other approach, different from normal, which we recommend to be combined with LAPE, because it's applicable to immunophenotypic shifts when there's no diagnostic sample, and also for longer-term monitoring when immunophenotypic shifts are more likely to occur. So different from normal, as applied in most labs, screens several plots of 2 marker combinations, and that's usually focused on the blast compartments rather than more mature precursor or myeloid cells. And they can be standardized by fixed gates for the most useful empty spaces, which is the approach we use in our laboratory, and that allows very rapid analysis. But it's also have the consideration there may be a higher background from normal controls than if you use, for example, 3 or 4 Boolean gates after you've gated your blasts. But to actually know what the background is, whether you're using the leukemic aberrant immunophenotype or different from normal approach, you need controlled bone marrows. And this is another recurring issue that comes when labs are approaching flow cytometric MRD and standardization. So, the sensitive and specific labs are going to be in the immunophenotypic empty space of normal blasts. So for control bone marrows, you are needed to require whether a positive result from a LAPE is a positive because it's leukemia, or actually whether it's because it's overlapping with where you normally see regenerating bone marrow progenitors. And the control bone marrows for different from normal analysis are required to define empty spaces and their background. But, empty spaces, you have to consider that there may be aberrant immunophenotypes within what would be an empty space, for example, in a completely normal bone marrow. But these aberrant immunophenotypes may have indeterminate leukemic potential. So what do I mean by that? Well, aberrant immunophenotypes with indeterminate leukemic potential are immunophenotypes that have observed in sort of growing numbers from CHIP and clonal cytopenia of unknown significance to low-risk MDS, high-risk MDS, and AML. So the presence of these will impact reporting the scientific validity and the clinical performance. Obviously, if you have an aberrant phenotype that, although it may be associated with low-risk MDS, the relapse significance of that is going to be different to an aberrant immunophenotype, which is associated with AML. And, some aberrant phenotypes are going to, observed in CHIP and clonal cytopenia. And to understand the range of these aberrant immunophenotypes with indeterminate leukemic potential, we need a sufficient library of reference control bone marrows, so with all subtypes. And an example of this, I mentioned the excellent paper by the MD Anderson when they validated their 12-color panel. And if you look at their figure from the 3 plots on the left, they had a clear aberrant phenotype on their diagnostic blast. So it was HLA-DR negative and CD117 positive. And in their normal bone marrow controls, that quadrant on the left, where they would identify MRD from, was empty. However, in a follow-up patient with CHIP, and then they knew that patient was negative for, this was a case of NPM1 mutated AML, and they knew this patient was negative NPM1 mutated AML by PCR, and this patient did not relapse subsequently. You can see that actually some events in that left hand upper left quadrant, which could have been quantified by MRD if this aberrant immunophenotype had not been considered as potential background. Now, as I said, their normal bone marrow was completely empty for that. But in fact, other normal bone marrows, including the one that was used in the NEQAS exercise, also had some cells in this region. So, that emphasized the point that, 1 or 2 control bone marrows is not going to be enough to know the full range of, the events that might fall into your empty gates. So those aberrant immunophenotypes, the indeterminate leukemic potential, I showed with HLA-DR, but there is a small number even with aberrant lymphoid expression, for example, with CD2, CD7, and CD56 from this study for patients with clonal cytopenia of unknown significance. It's less than 5%, but they were still present in that cohort of 80 patients. And then the very extensive study from the ELN MDS group led by Wolfgang Kern, when they were looking at aberrances in myelodysplasia, you'll see on the right that CD5, CD7, and CD56, in the gray, the non-MDS, again, that there can be a percentage of patients who will have aberrant expression of the lymphoid markers on blasts. So even with aberrant lymphoid expression, you need to be wary. So I'm going to conclude now by saying that harmonization leading to equivalent MRD results between laboratories is a key step for clinical evidence, which is going to be important not only for us reporting results to clinicians, but also for the clinical evidence by IVDR in the future. Although I haven't discussed processing, as we're all aware, processing includes stable cytometer settings, otherwise shifts in expression are not going to be accessible for MRD, and that throws up challenges with the newer cytometers. The core thing is that using recommended antibody core markers, and that will be updated by the ELN for 10 or more color panels by 2024. With NEQAS, there's now been development of an analytical EQA with reference values, which is will be a tool for us to monitor performance and competency, and therefore move towards standardized results. And that includes identification and ranking of the common useful aberrant immunophenotypes and different from normal for AML-MRD, the MRD percentage from CD34 positive blasts and CD117 positive blasts, and also the integration of control sample for percentage background. We've also incorporated sample quality assessments using absolute limited quantitation, and then that should progress in the future to looking at that by blast events and heme dilution. And then finally, lab by lab, there needs to be a range of control bone marrows to exclude false positives from aberrant immunophenotypes with indeterminate potential. And thank you very much for your attention. And I think we're now open to questions if you have any.
Sylvie, thank you so much. I'm sure that everyone will agree that that was a superb talk. And if I could just ask you to keep your camera on and microphone, we'll try and answer some of the questions that we've received throughout your excellent presentation. So the first question we've got, Sylvie, from an anonymous attendee: how many samples or cases does a centre need to see to become competent at MRD testing, and how regularly do they need to see cases to maintain this?
Yeah, that's an excellent question. I think the lab, first of all, would have to be confident that they could have enough control bone marrows. I don't mean by that normal bone marrows, but lymphoma staging bone marrows, to know that they could recognize control profiles and therefore define the empty spaces. And we would say that a minimum of 10 controlled bone marrows, but usually up to 20, and that would be refreshed every couple of months. I think the question that it comes also to the question of sort of lab processing and pre-mixes, because obviously that takes time. I think that's that's an individual lab decision about how how many, but obviously the results from the Spanish group showed that decentralized MRD testing was less prognostic than centralized. So as the ELN group, we are biased towards reference lab testing, because that just makes it easier. But I think that part of the aim with this EQA is for labs, even though they may not have many samples going through, to at least gain competency in the analysis, and then from that work backwards and work out how many samples they'll be processing. I'm sort of sitting on the fence a bit here, as you gathered. It's a difficult question.
And no definitive answer. Next question, then, Sylvie. Do you foresee any changes in guidelines or best practices for MRD testing by flow cytometry in AML in the near future? I mean, do you envisage, for example, electronic exercise as becoming incorporated into the ELN guidelines in any way?
So we're planning on updating the next ELN guidelines by next year, by the end of next year. And yeah, I think it will become part of those recommendations that people, that labs should participate in EQA, particularly electronic EQA.
I think, just allow me chair's privilege, that also leads into one of the other questions that I spotted on the list. The anonymous attendee asking if they expected the NEQAS AML exercise to follow the same style of reporting as we've worked on with your ELN electronic exercises. I think we are redesigning the format of the wet AML exercises that we're working through the MRD programs individually. So we will be rolling out changes to the AML wet exercise, but we will, I think it's important to reiterate that we are also going to be issuing electronic AML exercises to all of our participants. And I envisage that the format of those reports will be based on the work that we've been doing with yourself, Sylvie, and the rest of the ELN group, because that seems to be fit for purpose. So we will be rolling out electronic exercises to supplement the wet exercises, and they will be more in line with the ELN format that you've seen in this presentation from Sylvie.
But one thing I'd add to that is obviously, as Matthew knows, and with Liam and Stuart, is this has we've been learning from these exercises. So I think we will continue to evolve them as well, Matthew, won't we? With
okay, so the next question from Sandra Sapia. What is the consensus about denominators? Should we only include CD45 positive events or all nucleated cells?
So the consensus for the ELN is CD45 positive events. Obviously, there's the very, very occasional AML case, which is CD49 and 45 negative, but that's really rare. The reason for this is twofold. First of all, it's because that is what has been extensively prognostically validated, and the denominator of nucleated cells hasn't been. And secondly, it also overcomes some of the issues with variable samples, with variable lysis. Obviously that there are discussions about what represents most of what is observed by morphology, which counts nucleated cells, but with MRD, we're working on an objective measurement which has been prospectively prognostically validated using 45 positive events.
Thank you. And again, just using chair's privilege, I notice that also relates into another question further down the list, but if I could just answer that one. It's from an anonymous attendee. Do we know if UK NEQAS participants of the AML programme have all harmonised to report from the same denominator? They don't. We do provide a series of drop downs on the data entry pages, so you just select the denominator that you use in-house, and you'll be performance monitored against all participants and also your individual denominator cohort. Next question, let me see on the list. If a participant, if a patient has a particular molecular marker, such as NPM1, should labs be requesting molecular MRD or flow or both?
Okay, that's a really good. So by again, by ELN recommendations, the patients with a PCR marker, NPM1 or core binding factor should be prioritized for PCR. And this is particularly important post-course 2 in blood for NPM1, and then for sort of end of treatment monitoring to detect relapse afterwards. There is an argument for concurrent flow, but at the present, clinical decisions being made based on PCR. However, the argument for concurrent flow is that even with NPM1 mutations, which are, usually patients relapse with NPM1 mutated disease, but there are still up to 5 to 10% of patients who relapse with NPM wild type, and therefore flow. If you're taking a bone marrow for PCR, then it's actually quite good practice to do flow cytometric MRD monitoring it on as well for those wild type relapses.
Next question again from an anonymous attendee. Lots of shy people today. How should MRD status be integrated into risk stratification models for AML?
Okay, so on the slide that I showed with the ELN, so for good and intermediate risk AML, so starting with NPM1 mutated AML, the PCR MRD status, if it's persistent at high enough levels, will guide to a decision to transplant if they're persistent MRD after course 2. And with flow cytometric MRD in the intermediate risk group, if the MRD positive after course 2, that will be directed to allogeneic transplant if they're fit enough. And in the high risk patients, so that's whether they were high risk by genetics or high risk because of MRD after induction or consolidation, the presence of MRD before transplant will guide the decision about what sort of transplant and also transplant strategy afterwards. And then, of course, there's the evolving, so if a patient is MRD negative, and this has been most established for PCR, and they're undergoing monitoring at the end of treatment, then a conversion or a log increase by PCR will mean that would trigger preemptive treatment and consideration of transplant.
And next question, we still have about 10 minutes left, so if it's okay, we'll just carry on trawling through the questions. The next question is also from an anonymous attendee. What is your opinion on the future analysis of MRD using FlowSym or VISNI? Do you think that has a role?
Yeah, so we've done a lot of work with unsupervised analysis, and we think that it is definitely the future, and actually, in a way, it's another route to standardizing results. And we've worked closely with French collaborators, including André Plessard and Christophe Roumier, and also American collaborators. However, clustering by itself is not sufficient, in our opinion, to separate out aberrant phenotypes. So it's still a work in progress, but it is the future, and it becomes even more important when we're looking at the high dimensional panels.
I do apologise for that. We just had a little fire alarm go off during the presentation, so apologies for that. It proves that we are live. So next question from Dave Bloxham. Do you experience differences in antigen expression when looking at normal pediatric marrows compared to those of adults?
Yeah, that's another very, very good experience, and a question, Ben. Some people have more experience than we do. There are some differences, and I think that again comes back to the question of establishing your control profiles which are age appropriate.
Next question is from Anthony Carter. What bone marrow samples would you advise are used as control samples, given that the majority of bone marrow samples are to exclude malignancy?
Yeah, so what we work from originally and still do in majority what we call controlled pathological samples, so not normal bone marrow. I mean, obviously some labs have access to normal bone marrow, so by that we mean lymphoma staging, for example, with a normal bone marrow on screening by flow, and Also, we are now incorporating more regenerative samples after chemotherapy, particularly, for example, APML patients who have a negative PCR result and subsequently been shown not to relapse. So that's, that's really important to know what the patterns are on regeneration after myeloid type chemotherapy.
Okay, so the next question is from Boutra Badoui in France, and regarding the denominator for the precision of the proportion of MRD, why not consider the quantification in microliters now that it's made possible by the new flow cytometry analyzers, especially for the quantification of LSC at diagnosis, and correlate this result with known prognostic thresholds to define a more standardized quantitative threshold?
An excellent scientific question, and I think there's, what's going to be needed for this is clinical validation. So look forward to studies incorporating that.
Thank you. I think we've got time for a few more questions. So we've got a question from Patricia Brincat. What is the minimum sample viability required to issue a reliable MRD result, please?
Okay, so like most labs, we will process bone marrows coming through, whatever their age. But the assessment, I would say it's a qualitative assessment by forward and side scatter to look at viability. I'm not, I say what a minimum is. I think if the cells are poorly viable and there's no clear positive population, then that can't be, that result can't be used to qualify an MRD negative result.